So this video is going to be on colon and rectal injuries, some of the most testable trauma topics on the ABSITE, not because they're complicated, but because of the management decisions that are very specific. If you know when to repair, resect, or divert, you'll get these questions right every time. The primary objectives I'm going to be talking about in this video, you should be able to recognize mechanisms of injury, diagnose colon versus rectal injuries, and choose the correct operative management. That's exactly how SCORE and the ABSITE approach this topic. First, mechanism of injury. First, how do these injuries happen? Penetrating trauma accounts for nearly 25 to 35% of abdominal penetrating trauma. Second most common after small bowel injury. The mechanisms here are the direct wall injury, such as a knife or a bullet. There can also be a blast effect that causes mucosal disruption, and there could be mesenteric injury that leads to ischemia. In blunt injury, this is usually only around 1% incidence. The mechanisms are compression, that acute compression that leads to increased intraluminal pressure that leads to rupture. There could be shearing that separates the bowel layers. Rectal injury is often associated with pelvic fracture. So if penetrating trauma, think colon injury. Diagnosis is typically made with first physical exam. Key findings include abdominal pain or blood on rectal exam. It can be highly suspicious, but absence of blood does not rule it out. If the patient is very tender and is peritonitic, go straight to the OR. Don't wait for further imaging. If the patient is stable and you see blood on the exam, academically, you can do a proctoscopy or sigmoidoscopy, and on this you can find wall defect, hematoma, active bleeding. But the standard, obviously, in trauma is going to be the CT imaging with IV contrast. Here you may see pneumoperitoneum, retroperitoneal air, mesenteric air, or free fluid without solid organ injury. Nuance to imaging is a triple contrast CT where you use IV, oral, and rectal contrast. You can do this for suspected retroperitoneal colon injury or suspected extraperitoneal rectal injury. The key findings we can maybe see here is contrast extravasation, pericolonic stranding, mesenteric hematoma, or even extraluminal air. So now the important section, operative management. What do you actually do? First things first, you need to give the patient antibiotics. All patients need gram-negative and anaerobic coverage. Duration is typically, if the case is minimal contamination, then less than 24 hours. If there's a lot of contamination, gross contamination, then do 4 days as per the STOP-IT trial. According to that trial, longer antibiotics do not improve outcomes for your patient, so you don't need more than that. Step 2, intraoperative priorities. When you go in there and you do your XLAP, control the hemorrhage first. Next, address the major injuries, and then lastly, evaluate bowel. The biggest thing there is infection, so get the life-threatening stuff out of the way first. Surgical decision-making. This is the high yield that you need to remember for all your life. Primary repair. You do this when there is colon or rectal injury less than 50% of the circumference of the injury and there's viable tissue. The technique you want to remember is you want to close these transversely to avoid narrowing. Patients that you need to consider for resection and primary anastomosis. This can be used for larger injuries but still stable patient. And there's adequate perfusion, meaning they're not on pressors, they're not hemodynamically unstable, so forth. When you have those hemodynamically unstable patients, you need to consider doing those resection and diversion, which means creating an ostomy. You do this for severe contamination, hemodynamic instability, and if there's just general poor tissue viability. You must be prepared for an ostomy in all cases going into this. Key rectal injury concepts. Here's where people get questions wrong. You must be able to distinguish between intraperitoneal rectal injury and extraperitoneal rectal injury. For intraperitoneal rectal injury, you can treat it sort of like a colon injury, where you either repair or resect, like we've talked about. For extraperitoneal rectal injury, it's a little bit more complex and often requires diversion or additional measures. And this distinction is very heavily tested. I'll attach one of my papers that is a case report on extraperitoneal rectal injury, where we did not do a diversion. And in that paper, I kind of go into specifics about, what are those things that you're thinking about when deciding whether you need to do a diversion for these patients. Postoperative care is very important. So after operative management of colon or rectal injury, postoperative care is focused on infection control, anastomotic integrity, and return of bowel function. Monitor for the following complications. You're watching for the anastomotic leak, intra-abdominal abscesses. That can actually be more common with laparoscopic surgery. But again, this can happen with open surgery, wound infections that are very common with those grossly contaminated open surgeries, and sepsis. You want to watch for fevers, tachycardia, leukocytosis, or if the patient's just complaining of increasing abdominal pain that's just not going away. You may want to, if you're concerned about this, you need to get a CT scan with contrast. Looking for return of bowel function, want to wait till they're starting to have flatus or have a bowel movements. You can advance their diet as tolerated. And studies have shown that early enteral nutrition, when possible, is preferred. So the ERAS protocol for elective cases often prioritize advancing them, on clears or regular diet, almost on post-op day 1 or post-op day 2. If the patient undergoes diversion, important to think about ostomy care, early stoma assessment for viability, patient education, and involve those ostomy nurses early. They're really good at what they do, and they can, help the patient understand, how to put these on, how often to change it, and all of these things that are essential that we often forget about. This is huge for real-world care, and boards love complications like ischemic stoma. So, make sure you see your patients post-operatively and make sure that stoma is intact and pink. Follow-up depends on the operation performed. For primary repair and anastomosis, the biggest thing is you're monitoring for a leak. This happens around the 5th to 7th day is the highest risk. And then you can just do routine surgical follow-up. This is in contrast to patients who've gotten a diversion. Those ostomy patients, you need to plan for an ostomy reversal because they're most likely going to want it. This is typically done after healing is confirmed. There's no further infection and the patient is optimized. This usually takes around 2 to 3 months, but it can be patient-specific. In special circumstances, when patients are hemodynamically normal and have no infection complications, reversal of colostomy can be done within 2 weeks if a water-soluble contrast enema shows healing of the distal colon or rectum, and this is by the East Trauma Guidelines. Preoperative preparation for these patients include rectal examination of the colon stump to rule out stricture or mass, and this is usually followed by a water-soluble contrast enema or a sigmoidoscopy to fully assess the stump patency, healing, and length. For rectal injuries, especially extraperitoneal, the big things you need to follow up and know are the risk for pelvic sepsis. They may require further imaging before reversal, and usually you want to get a couple other people on board. They may require a multidisciplinary follow-up, and you may want to defer to a colorectal surgery to do this, specifically if the rectal stump is very low or any other complications you could foresee. Remember, postoperative complications, an anastomotic leak, abscesses are usually the common testing angle for the score. And lastly, we'll just kind of touch on those high-yield pearls we previously already talked about, such as penetrating trauma is usually the common cause of colon injury, behind small bowel, blood on rectal exam. It can be concerning, but not required to make that diagnosis of colon or rectal injury. If a patient is peritonitic, immediately take him to the OR. For patients that undergo CT imaging, you're looking for air, fluid, or stranding. For patients that have colon injury that are less than 50%, you can consider a primary repair. Remember to do this transversely to avoid narrowing of that bowel. And for severe injury patients, consider resection or diversion. And lastly, just remember the stop at trial for these patients do apply. Typically 24 hours or less for patients that have minimal contamination versus 4 days for patients that are grossly contaminated. And lastly, remember that difference between repair versus resect or divert. So stable or limited injury, repair; severe injury or instability, resect and divert. That's the entire algorithm. So this video is going to be one video of an entire series I'm going to be basing off this SCORE curriculum. I'm going to literally be going through every single module to create a curriculum that helps visual learners and people that like hearing things kind of know all of these basic and fundamental concepts. So you can study once and cover everything, go through the videos as you wish. Thank you for watching. Have a good day. And I hope that you stick around for more videos.